welcome. You're watching Living with COVID. We're joined by a panel of doctors who will help us navigate with the new normal as India enters several phases of the unlock. What are the do's and don'ts that one needs to follow as we get on with our daily lives? We have today with us Dr. Akashkumar Singh. He's a director at the Sundar Speciality Hospital, joining us from Vadodara. He specializes in internal medicine and diabetes. We also have Dr. BK Sundar, who's a consultant physician, internal medicine and cardiology from the BKF Hospital in Florida. Appreciate both you doctors for joining us and taking out your time. Many patients at this time are apprehensive of visiting hospitals and clinics for physical tests or checkups. They're afraid that they may contract the infection if they go to a doctor. So Dr. Singh, can you explain some of the protocols that you're following, segregating patients, and making sure that patients who come to visit you for routine checkups do not contract the infection?
First of all, I must tell you that I have two hospitals here. One hospital caters to COVID patients, and the hospital which I do my OPD is a non-COVID hospital. Second thing I must tell you is that I have not closed down my hospital even for a single day during the lockdown, because being a person who is supposed to manage COVID patients, it was I felt it was my duty that I should make day-to-day observation, make day-to-day improvement in my clinic, in the safety measures, update myself, and implement all the safety measures that are required to prevent my staff and my patients from getting the infection. And we have been doing this continuously from March end, when the lockdown has been implemented. In the morning, before I come to my consulting, everything is basically sprayed with 1% sodium hypochlorite solution. And the appointments, the receptionist will ask whether the patient has fever, cough, cold, any respiratory complaints. And if such patients are there, then they are called to the different hospital. All the chronic segment patients are called spaced out, and we can accommodate around 8 to 9 patients, maintaining a distance of 2 meters, and we see to it that not more than 7 to 8 patients are called at a time. After the OPD is finished, we have OT also, because surgeon is also there with us. We fumigate the entire outdoor setup and shut it down, so that next day again it is absolutely free of infection. All the staff and myself are basically given impervious gowns which are autoclaved daily, gloves, double mask and face shields. So all this is meticulously done. I also see patients in a three-pronged approach. First of all, my staff takes the vitals, blood pressure, temperature, everything. Temperature is with a gun basically, and enters in the computer. Then my medical officer takes a brief entry, enters the computer, and I see the patient last. So the time with the patient for all the three sets of the nursing staff, reception staff, the OPD staff, and the medical officer and myself is divided, so that each of us has shorter exposure to the patient. So all these measures have been pretty useful, and fortunately in the last 4 to 5 months, we have not had any serious infection on my staff members.
All right, well, that's quite an achievement, Doctor, to boast about, and very important that you are in fact segregating your patients in a manner that you are. Dr. Sundar, would you like to explain any protocols that you're following, especially in examination rooms? I think that's one of the big fears with several patients being examined in the same space. So what are the kinds of protocols that you're following?
The patients coming to the hospital are also quite wary of coming to the hospital because they think that they might contract the disease. First of all, we must definitely reassure them that we are taking all the necessary precautions to make sure that they are safe. That's very important. And once they come in, it's quite intimidating for them to see doctors in a different setup. It's a new normal for us. We are wearing all the face masks, the respiratory masks, the visors, the gloves, which we are not used to basically. And the doctors are also not used to, and the patients are also not used to seeing the doctors like that. So it can be quite intimidating as well. So basically, when they come into the clinic, we make sure, into the office room, we make sure that they come alone without any attenders, and even then they're coming alone. Because of the spacing, we make sure that they're sitting apart. They're sitting at least 6 feet apart. And basically, we need to tell them that we're examining them only if it is absolutely essential. And this is a new normal again, because going close to the patients also can basically two-way. I mean, it is a risk not only to the doctors but also to the patients. And if there is something to be examined and they're on the couch, and obviously the couch will be, after we examine the patient, we normally sanitize the couch once the patient leaves the office room. And in some places where there is a constraint of space, then they might have a plastic curtain between the patient and the doctor so that you interrogate the patient and talk to them and make sure that they also feel comfortable and safe. The most important thing would be, again, for the room where you are examining the patient should have adequate ventilation so that the windows are kept open and you don't switch on the AC for whatever it's worth, and make sure that the air, there's a fan which will circulate the air to drive away outside the inside air to the outside. So many things that we need to make sure and ensure the safety of both the patient as well as the doctor. And this is a new normal for us. Now, doctors are not used to seeing patients just interrogating them and then letting them away. We are used to the age-old school of the history taking, the percussion, auscultation, and palpation. So these are the sort of things that we normally do, but we are now doing a different approach to the patient. So these are some of the things that we normally take. And absolutely essential is the patient should wear a mask when they come into the hospital, when they come to see us. So without a mask, they are not allowed to enter to the hospital at all. And they all sanitize their hands, and we sanitize their hands and touch them or examine them if at all we need to examine them. So either way, the basic principle of sanitizing, the masking, as well as social distancing is absolutely taken care of.
All right, so that's very interesting. As the number of COVID positive cases, there also seems to be a shortage of space in hospitals in such a scenario. Dr. Singh, what's your advice on home-based COVID care?
Actually, I'm a member of COVID committee for control of COVID in Baroda, and yesterday only we had a meeting with Chief Minister Mr. Rupani. And my suggestion was that we should now go ahead with a massive program of home-based COVID care. Now, the thing which I have seen is that the patients are getting less frightened and doctors getting more frightened with COVID-19 because there has been mortalities in the doctors. So, a lot of patients want to be managed at home and they can be managed at home. So, what I have suggested to them is that patients should be given guidelines. They should be monitored by, there are a lot of physicians, almost 200 physicians in Baroda. They can take up 5-6 patients who are willing to get monitors who have got mild disease, and these patients should be isolated to one room. The second principle is that only one person from the family should cater to them, and the person who caters to them should go only if required to the room of the patient, wearing a double mask and gloves. All the utensils and clothes of the patient should be sanitized by 1% hypochlorite solution. The patient should himself be wearing mask most of the time till he sleeps, and this mask should be changed every 8 to 10 hours, or if it gets soiled or wet, the patient has to do teleconsulting with his healthcare provider at least once or twice a day, morning and evening, and whatever charges are there, they can be fixed on daily basis. And pulse oximetry of the patient, temperature according to the patient, all can be done by the patient himself, and that should be sent over to the healthcare provider. In one of my patients, it is so transcribed that his pulse was 80, his saturation was 84, and his pulse was 98, and he was thinking that his oxygen saturation is 98 and pulse is 84. So I told him you are having breathing difficulty. I told him to send over the image of the pulse oximeter, and I could immediately make out that the saturation is 84 and pulse is 98, and he was immediately admitted and he could be salvaged. The patient should not be on home-based COVID care if his temperature is persistently high, more than 100 persistently, or if he is having dyspnea or shortness of breath, or if he is having saturation less than 94, although the government is little more lenient, but I have kept 94 as the thing. Then the patient should also be asked to walk for 6 minutes, and oxygen saturation after 6 minutes should be checked. If it is dropping by more than 4 to 5%, that is an alarm sign. Apart from that, other symptoms which may develop, like confusion, alteration in sensorium, or weakness of any of the body, any other alarm system is developed, then the patient should be immediately shifted to the hospital. With home-based COVID care, maximum patients can be managed who are having mild disease, and the overcrowding to the hospitals can be avoided. And I am happy to say that this has been taken up by the Chief Minister Committee, and they will be implementing it in Boda in the next week itself. And home-based, there will be guidelines, there will be charges per day, and everything will be streamlined for home. So that will reduce the burden on the hospitals.
All right. Now, Dr. Sundar, it has been seen that many COVID patients die because of heart attacks. Are people with existing heart disease at a higher risk of complications as a result of COVID?
Yes, I mean, we have seen quite a number of patients with comorbidities getting the COVID-19 infections. I mean, we don't have a data as yet as to tell us how many percent of patients with comorbidities develop the COVID-19. But I mean, I suspect they have, we are equal to get the COVID-19 infections. Having said that, people with comorbidities, they have a poor prognosis when compared to people who don't have comorbidities, and especially in elderly population. So this is the data coming out from China, where they found out that they've studied about 1,600 patients with comorbidities, and they found that the cardiovascular disease was the third most common comorbidity in these patients. So coming to that, I mean, this COVID-19 is a sort of an inflammation which is happening on the vessel walls, and we all know that, I mean, over a period of time, we have found out that it is more of inflammation of the vessel walls, especially the lungs and the heart and those kind of things, which can cause the rupture of the plaque, which is already present, and that can present as an acute coronary syndrome. And they can also affect the myocardium, that is the heart muscle, and that can cause a myocarditis. And that what we call as a myocarditis, and that can cause what we call as a heart failure. So we see so many other cardiovascular diseases. We see arrhythmias, that is a disturbance in the heartbeats, and then we see heart failures. And unfortunately, people who are non-survivors have more died due to heart failure. About 50% of them have heart failure. Compared to survivors who had only 12% of survivors had heart failure. So that's one of the biggest marker of death in patients who have got heart disease. So basically, the heart failures and the myocarditis and acute coronary syndromes are more predisposed in patients who got COVID-19, and we have seen more and more patients with COVID-19 patients present as heart attacks. So that's a new presentation. Most important thing to remember is that more and more patients, it's better that they recognize the symptoms of COVID-19 early and present early so that they can be treated and prevent certain complications, especially in the elderly population, people who have got comorbidities. Because what they found out is that the case fatality rates for patients with comorbidities are high. I mean, it's about 10% when compared to people who have got no comorbidities, about 2%. So to prevent that, so basically we have to make sure that we recognize these symptoms early and start treatment early, and to make sure that we don't push them into complications of heart failure and myocarditis and arrhythmias and death.
All right. Well, thanks so much for that. Now we're going to slip into a very small break at this moment, but coming up on the other side, we're going to talk about how to differentiate the symptoms of COVID from the symptoms of a common flu.
Knowledge Partner, USV, your reliable healthcare partner.
Welcome back. You're watching Living with COVID. Now, Dr. Deshpande, if you could speak a little bit about the dangers of obesity, especially due to the fact that people who have diabetes are eating more, perhaps because they're home or they're exercising less due to lockdown restrictions. And that is something that has compromised the immune system. And how can one effectively manage all these issues?
I've been handling of late 30 to 40 COVID patients, 20-25 admitted, 15-20 OPD patients on a daily basis, and let me tell you that it is very difficult to segregate COVID-19 from non-COVID-19. In fact, I have seen patients with all sorts of complaints turning out to be COVID-19, and our being a surgical setup, many of the asymptomatic patients who do not have anything have turned out to be COVID-19 positive on RT-PCR testing as a pre-op test. Basically, at this point of time, what I consider is that all patients who are symptomatic, unless proved otherwise, should be considered COVID-19 patients. What we do is that we follow up these patients. We all the patients with acute illness, we tell them for home quarantine. We do the basic tests, including CRP. We follow them up over a couple of days. And if the patient is not improving, then we go for further detailed tests. HRCT test has turned out to be a very rapid screening test for these patients because the yield of HRCT is very, very high and it is a very fast test. Because RT-PCR basically it takes around 1 to 2 days for collection to occur, and then the report, it takes around 24 to 48 hours is the turnaround time to get the report. Only patient where I am little reassured that it is not COVID-19 is suppose an old patient of COPD or asthma. If he comes with similar complaints with a very productive cough, because most of the patients of COVID-19 are not having productive cough, they are having more of a dry cough. So there are very, very few distinct characteristics which can differentiate COVID-19 from non-COVID. But at this point of time, looking at the versatility of the presentations, I can say that all acute illnesses should be considered COVID-19 unless proved otherwise. I have seen all the GI complaints, patients mostly turning out to be COVID-19, strokes, patients turning out to be COVID-19, cortical vein thrombosis, patient confusion, patient turning out to be COVID-19, MI, patients turning out to be COVID-19, even a sickness which is just fever, nothing else, patients turning out to be COVID. So at this point in Borda, more than 90% of the acute illness patients are COVID-19 unless proved otherwise. And I don't think there is any merit in differentiating COVID-19 with the non-COVID-19 system. We should consider all patients as possible cases of COVID-19, monitor them, isolate them, give them the home isolation guidelines, and test them with HRCT test or RT-PCR on an earlier basis if the symptoms do not resolve within 2 to 3 days.
All right, that's very interesting. Now, Dr. Sundar, if I can come back to you, speaking about heart patients, what time or what can be managed at home, and what are the symptoms that are typical telltale signs that they must be hospitalized?
Obviously, patients who are having heart disease, who have had a heart attack in the past and who have had some stents done, or who are hypertensives, they have to continue taking their medications as usual. Most important thing is they should have the supplies of medicines for at least 30 days. Make sure that they don't skip. Make sure that they have a healthy, balanced diet and have some reasonable physical activity within the home, because you're not allowed to go out, and make sure that you are staying indoors. Having said that, doesn't necessarily mean that they should default on their medicines. They have to take medicines regularly. As and when it gets over, they have to replace it and replenish it. Most of them, if they have a chest pain, obviously they have to come to the hospital. They should not neglect signs of, say, chest pain or breathing difficulty, wherein they have to have medical help ASAP. They should not neglect these signs. Few of them will have some twinges here and there, niggles here and there, which are not like their usual cardiac niggles, in which case they can consult a doctor, either do a teleconsult or a phone consult, and then make sure that they are not missing out on anything. Sometimes it can be very tricky. It can be very tricky in the sense that it's very difficult to differentiate between a cardiac pain and a muscular pain most of the times. And the patients sometimes they confuse it with what we call as gas, and then they start taking in the gas pills, that is the pantoprazole or ranitidines and things like that, and they end up coming to the hospital late. So let them not get carried away. Let them make sure that they are not missing anything. They can call up their routine doctor to find out what's happening, and in case they have a problem, they should not hesitate to go to the hospital. And this is a pandemic which has given us a very a different situation altogether. We are asking people not to come to the hospital, wherein earlier we used to tell them to come to the hospital, but now we're desisting them from coming to the hospital. Right. But in situations, we have to make sure that they come to the hospital, get an ECG, and make sure that it's not cardiac and they're not missing out on anything major.
Okay, now speaking of hospital care, Dr. Singh, can you explain what the treatment costs or modalities are when a patient suffering from COVID is admitted to the ICU for treatment? And there's a lot of curiosity around the role of remdesivir in the treatment of COVID.
So we have had 50 plus patients in the ICU because we started our COVID center a couple of months back. And what I can say is that in patients of moderate to severe disease, you have to be very, very careful. You have to monitor these patients with inflammatory markers like CRP, ferritin, LDH, and IL-6. And you have to monitor these patients clinically, their vitals, their urine output. You have to monitor these patients for thrombotic state with D-dimer. And it is very, very rampant that if you miss out the treatment in time, then your patient will definitely complicate. But we have had fantastic results as far as the treatment of COVID is concerned, is a message I want to convey. And the drug which acts most fantastically in our patients are the steroids. Steroids are the number one drug and started in time. They produce remarkable improvement in our patients. And either you can use dexamethasone or you can use methylprednisolone. We use more of methylprednisolone. The data of dexamethasone is from UK, where it was mainly shown to reduce death in ventilated patients by 1/3 and in oxygen requiring patients by 1/5. But in India, methylprednisolone is the drug of choice and it has to be used judiciously, not in all patients. About the remdesivir is the newest arrival. It basically blocks the viral replication. And the trials available favoring the use of remdesivir has been done by the parent company, that is the Gilead Pharmaceuticals, in a small set of patients where they have shown that death rate is not improved with the use of remdesivir, but there is some improvement in the hospital stay to the tune of 3 to 4 days by merit of early viral clearance. Now, we have been using remdesivir in patients who come with oxygen requirement or whose oxygen requirement increases. We have used in several patients. And I will not say that I am not happy with the drug. I am pretty satisfied with the drug. Our patients are doing well. And we are using remdesivir in patients who require a good amount of oxygen or whose oxygen requirement is increasing. Apart from this, if the D-dimer is crossing 1,000, we are using low molecular heparins. They are also one of the key drugs. And some of the patients who do not get their D-dimers in control towards discharge, we are switching them on lower oral anticoagulant agents. So these are broadly the drugs, common drugs which are using. We are satisfied with the use of drugs. That is what I will, but it is not to be used in mild disease and not to be used indiscriminately. That is another message I have to convey.
All right, well, I think that's a really important perspective. Thank you so much, doctors, for joining us. Thank you all for watching at home. Goodbye.
Knowledge Partner, USV, your reliable healthcare partner.